Hello, I'm Carl Hynett. You may remember me from the news some years back, escaping from a burning tank. I was flown for treatment to Birmingham, and I'm currently standing outside the QE hospital where the burn centre that treated me is based. This film is designed to help you on the journey you're about to go through as a burns patient, from injury through initial treatment, rehabilitation and eventual discharge. Once you have been admitted to hospital, you will be looked after on the burns unit or intensive care unit in a single or double-side room.
Some patients who have very large burns, or perhaps those who've inhaled smoke or have medical conditions beforehand, might be sicker than other patients, and for this reason they may be managed on the intensive care unit. The main difference between the main burns ward and the intensive care unit is really the level of support we can give patients. Sometimes their breathing might need extra help, or their blood pressure, or other body functions such as kidney and liver. So patients will often be on intensive care when they need that extra support, and then as they get better they can be stepped down towards the normal ward as their organs improve. Burns patients are looked after in a side room because when they have a burn injury and some of their skin is damaged, that removes part of the protective layer which prevents infection. So to reduce the chance of them getting any infection, we prefer to nurse them in side rooms, and also patients find they prefer the privacy of a side room in a lot of cases.
We like to keep the side rooms warm. When you've got a burn injury, your body reacts by raising your own body temperature to burn more energy to try and heal itself. So by raising the temperature in the room, we can actually stop your body working so hard.
Patients will often have blood tests as part of their treatment when they have a burn injury to check that the kidneys and liver are working well and to monitor signs of infection. This might be done fairly frequently, perhaps every day, and this gets less frequent as time goes on. Patients admitted with burns will often have lots of lines and catheters and drips. The main types of lines we use are what we call a central line, which goes into one of the big blood vessels, often in the neck or the groin. And this is used to give various drugs, to give fluids, and also to take regular blood samples. And it also allows monitoring of certain body systems. The other very common type is a urinary catheter, so a catheter that goes into the bladder, which will drain the urine so you don't have to go to the toilet.
In the first stages of an injury, it is necessary to actually disturb patients through the night, do their blood pressure, take their temperature. And the reasons behind that is we need to be able to respond quickly to any changing condition.
My injury happened at home. I fell asleep in front of the fire, woke up in a daze, and because I got lots of hairspray on, my hair just ignited.
I had a drum of fuel I was lighting a fire with, and I hadn't put the lid on correctly. And walking back away from the fire, the vapours exploded the drum I was holding.
We phoned the ambulance and I was admitted to the QE. I would say I got there about an hour later.
I managed to drive myself to the hospital with my son, just in case something went wrong. I hadn't quite got a driving licence at the time, but it was quicker than calling an ambulance.
Depending on what time of the day or night they're admitted, they will have a full nursing admission completed. First things we'll address is their pain relief. Then we'll start assessing their wounds, and that will involve cleaning some of the wounds and also getting an early dressing on as well to make them as comfortable as possible.
During your stay in hospital, you will meet lots of health professions that will see you after your burn injury. They are each responsible for a different aspect of your care. There is also some overlap between the roles of the therapists.
Nutrition plays a really important role in promoting wound healing and keeping patients well. The larger the burn, the more calories, the more protein, the more energy that patient is going to need to heal. They'll also need extra sort of vitamins, minerals to get that wound healing. If it's a larger burn, what we'll have to do is put down what we call a nasogastric tube. Unfortunately, it has to go up the patient's nose and go into the stomach, and what we do is we feed them down that way. So we give them liquid feed, which is a high calorie, high protein feed.
Some burns patients experience swallowing difficulties. This can be due to burns to their face, their neck, around their mouths, or inhalation injury. Sometimes difficulties with swallowing can mean that patients are at risk of something we call aspiration. Aspiration is when food or drink goes down the wrong way, so into the lungs rather than into the stomach. Our role is to assess that a patient is or is not able to swallow safely and to prevent that risk where possible.
Within the Burn Centre and intensive care, we have a team of research nurses that run various different research trials. The research trials that we run may be observationals, where we see patients following a burn injury to take things like bloods, or there may be dressing trials or drug trials where we try new dressings or drug therapies. All patients will be considered for research trials depending on the trials that we have running at the time. If you want some independent advice, you can always speak to your burns nurse or burns doctor. They will have knowledge of the trial but won't be involved directly in the conduct of the trial, so they will be able to offer you impartial advice.
We have a consultant-led ward round every day of the week, including the weekends. It won't necessarily be the admitting consultant that you see every day, but you will see a member of the burns team.
There are different ways of treating a burns wound. Some patients will require an operation, whilst other patients can be treated with dressings to help their wound heal. The doctor and nurses will talk to you about the treatment you will receive and why the treatment they suggest is best in your case.
Burn wounds can be managed in two main ways. If we think that a burn is fairly superficial and it's likely to heal well on its own, then this tends to be managed conservatively. And by that we mean it's treated with dressings until it heals.
We take wound swabs frequently throughout dressing changes. The reason for that is we're looking for bacteria that may be colonised within a burn wound. What we mean by colonised is bacteria that's growing within the wound and it may not be causing any problems. If that colonisation reaches a point where it becomes an infection, we can then accurately treat with the correct antibiotic.
In burns which are a bit deeper or in certain particularly important areas, if we think this would heal better with a skin graft, then surgery is often chosen. And this basically means taking you to theatre, taking away that burnt, unhealthy tissue and replacing it with a skin graft.
I was in the QE for approximately a month. I had a couple of operations and that included a split skin graft.
I was in hospital for a month, had 2 operations to graft my skin.
You will now see a short animation to illustrate a skin graft procedure. The burn wound is debrided by the surgeon to prepare it for the new skin. This means removing all the burned skin and leaving behind healthy tissue. The surgeon will take a thin layer of unburnt skin, this area is called the donor site, and will heal by itself. The donor site is like a graze and you will probably find that it is more painful than the actual burns at first. Sometimes the doctors mesh the graft. This allows the donor skin to go further. The donor skin is then placed on the burns wound. It will be secured in place with stitches or staples and sometimes special skin glue. A dressing will be placed over the top and left in place until the first graft inspection.
One of the methods used for securing a skin graft is staples. These are essential, they help keep the graft in place. Sometimes there can be quite a few, so when it does come to removal we do ensure that you have adequate pain relief for that.
The first one, they gave me ketamine, so I didn't really feel them doing the dressing changes.
My bandages were changed twice a week using ketamine, and I knew very little about my bandage changes till I woke up.
Dressing changes will be done frequently, usually every 2 to 3 days. After surgery, there might be a bit more of a delay for doing the dressing changes. We may opt to leave them up to 5 days before we have a look, and that's just to give the graft the best chance of taking. Unfortunately, one of the major problems with burns are they are very painful and they can also be very itchy. Dressings can go a little way to help with the pain management side of things, but unfortunately itch is a very common problem.
If the itch or the discomfort is becoming troublesome, then there are various medications we can use to improve that. And once the donor site is healed and the dressing's been removed, then you'll be advised to apply moisturising cream to the area, which will also improve the itch.
Your wound will be reviewed regularly by the doctors and nurses to see how it is healing. After each review, they will tell you the progress of the wounds and the treatment plan will be updated.
It's important to mobilise and keep moving after your burn injury because this can help your body's natural healing process. It can help by increasing blood flow to certain areas of the body, the skin, and for example the arms and the legs. It can also help to reduce swelling, which may then in turn reduce some of your pain caused by the pressure from the swelling.
You may be asked by your therapist to wear a splint. Splints are designed to hold your hand or your limb in a certain position. Something that you might see when you're on the ward is a neck splint like this, or a hand splint like this. You need to wear the splint for the designated amount of time, and this will be discussed by yourself and the therapist.
Patients are required to complete an exercise programme during their hospital stay. This will be prescribed to you and tailored to your needs and functional requirements and goals by your burn therapist. This may include stretching exercises for any tight areas, strengthening exercises for any weak areas, and also exercises that may get you a little out of breath and increase your heart rate to help strengthen your lungs and your breathing muscles.
When you wear a hand splint such as this, you may find it very difficult to do things for yourself. It's very important that you wear the splint for the amount of time that the therapist wants you to. However, we do think that you can take it off to do your functional task and then put it back on afterwards.
Some patients notice changes to their voice after a burns injury. Generally, patients' voice quality will return to normal. Sometimes patients might need a little bit more help after discharge, so speech and language therapy are able to follow them up and continue to support them with their voice recovery.
Patients with burn injuries often have lots of medication, particularly when they're in hospital, and we try and reduce these as much as possible before you're ready to go home. These are usually continued until the wound is healed, and occasionally for a little bit of time afterwards, but we would review this when we see you back in clinic, ask you how your symptoms are, and we can advise you then whether these drugs need to be continued. Whether or not a burn wound heals with a scar depends on several factors, so the deeper the burn and the longer it takes to heal, the more likely it is to heal with a scar. But also people with certain skin types, such as very pale skin or very dark skin, are also more likely to heal with a scar. Whether a wound is likely to heal with a scar or not will affect our decision whether to offer you surgery, and so this will be part of the discussion we have with you, and we'll try and give you a realistic idea of how likely it is that you'll heal with a scar, but sometimes this is a bit unpredictable and we'll only know once the burn is completely healed.
Once the burns wounds have started to heal, the scar management therapist, often an occupational therapist or a physiotherapist, will see you to discuss what to do.
There are a few different types of scar management treatments available. One is the pressure garments and the other is silicons. There's a range of different silicone products available. Silicone has been shown to soften and reduce scarring over time. Pressure garments are used to flatten and soften scars. They come in a range of sizes and different designs. They're quite stretchy and they're made out of lycra. You'll be asked what colour you want on admission, and then you are expected to wear it for up to 23 hours a day. The scars may become very dry. It's very important that you moisturise and massage them 2 to 3 times a day. This will help to keep them hydrated and stop them from drying out and cracking.
Part of the healing process is getting out and about. There are a few places you might be interested in visiting with your friends and family when they come to visit you, such as the hospital canteen, Costa Coffee, the prayer rooms and the fruit stall.
When you are becoming ready for discharge, we will sit down as part of the multidisciplinary team, so the therapists, the doctors, the nurses, and we will start to plan that with you. It may be that you might require some social service input if you need extra care initially for going home, so that will be very much discussed with you and your family. It can be a little bit of a lengthy process, so we may start it a little bit before you feel ready to go home, but we'll make sure that everything is fully in place for you. If there's any aspect of a patient's care that they're not happy with during their stay with us, we'd first ask that they would try and discuss it with the nurses. If they don't feel able to, there is a patient advice and liaison service within the hospital that can have that conversation early with us, so they can be the liaison between the patient and the ward, and they can advise how to take things further if necessary.
Once you're at home, you will still have access to the burn service and may have to come back to see the doctors, nurses and therapists for your continuing care.
When patients go home from the burn centre, they will still get continued support from us. One thing that we'd ask is that they come back for a wound management appointment. They'll also get a consultant appointment, usually within about 6 weeks of discharge. They will see some therapists on discharge as well, maybe the occupational therapist, and maybe some ongoing physio support as well.
The pain was managed well when I got home. The only thing was I felt a bit vulnerable. I didn't want people to see the way I looked. I wouldn't even go near the windows. For fear someone saw me, but as time goes on, you improve and you start going out and about again.
I burnt myself 3 years ago and my skin is still changing now, it's still improving. I can go out into the sunshine again. I don't have to worry about getting burnt from the sun.
It's very important that you wear Factor 50 sun cream every day. Your skin's lost its natural barrier against the UV rays, and if you do tan your scar, it will remain dark, and as your tan fades, your scar will have picked up the pigment and won't fade.
What we find with our burns patients is when they go home, patients can often be quite worried about the diet. So what we'd often do while they're in hospital is talk to them about the diet after they go home. We find that patients will often still be using up high amounts of calories, high amounts of protein. They might have lost weight while they've been in hospital. So what we want to do is start building back up their strength, start building back up their exercise tolerance, building back up their daily living tasks.
Patients can access our service after discharge. Often going home can be a really significant milestone, and then a whole load of other issues come up, some of which patients can struggle with. So we do offer outpatient appointments for after people have gone home.
Patients can talk to anyone about how they're feeling after a burn injury. Sometimes patients find it helpful to speak to loved ones, but often it can feel more helpful to speak to a trained psychologist, which is why we're there.
Patients with burn injuries often ask us when they can return to work and their normal activities. And this will really depend on what your job is and how large your burn injury is and what part of the body it's affected. Generally, we would advise that you can return to work once you've got either no dressings or very minimal dressings on, and once your function has returned back to normal.
We also have a hospital at home nursing team that actually bridged the gap between hospital and home, so they can liaise with district nurses and offer expert burns advice to those nursing teams. They may also come and visit you in your home and help with wound management there as well.
The burn centre is a very special place. Every time I come back here, I feel a sense of joy. It made me better, it healed me, it gave me hope.
It's 3 years later now since my injury, and things have improved so much. I'm really happy with the progression. I go out, I do everything I used to do before.
Please don't give up. Work hard at it. The more effort you put in, the quicker you'll be able to get home, the quicker you'll be able to get your life back together.